So here we're going to talk about managing the patient with HIV. Approximately 1 in 100 Americans are infected with HIV, and unlike 30 years ago, the treatment for HIV is much better, and so we have HIV patients living longer and longer, even up until life expectancy. So managing a patient with HIV is going to be something that the clinician is going to want to be very familiar with. So again, if you saw my lecture on opportunistic infections, this should be a familiar chart. This just shows HIV throughout the world. The U.S. falls within the 0.5 to 1% prevalence and is rising with the increased immigrant population. However, the problem is most significant in sub-Saharan Africa, notably South Africa and countries surrounding it. It's also notable in Southeast Asia and in Russia and Ukraine. In the U.S., it's most prevalent along the East Coast, Florida, along the west coastline of California, but really any urban center would be considerable. I mean, if you look here, you've got Utah, which is relatively not infected, but here's Salt Lake City, and it's as brown as the East Coast. So urban centers are infected too. By race, it's about 46% black, 35% white, and 18% Hispanic. So there is some disproportionality in HIV prevalence in the U.S. Now, how is HIV transmitted? In the U.S., about half of it is going to be men who have sex with men, is going to be how HIV has been transmitted. The rest is going to be through IV drug use and heterosexual contact. But compare this to worldwide. Worldwide, the common source of infection is by far heterosexual contact. And men who sleep with men, sexual contact, only actually makes up less than 1% of the worldwide cases of HIV/AIDS. So while in the U.S., you could probably consider AIDS to be a homosexual problem, worldwide it's actually indeed a heterosexual problem. It's a problem for everybody. Okay, so some basics of HIV and transmission, and I'm just going to give the same talk as I gave in the opportunistic section about HIV. It's spread parenterally via infected body fluids, so breast milk, semen, blood, and so forth. It can also be spread vertically, mother to fetus, during the pregnancy, but this is extremely rare today, as we're going to see. There are medications we give to the pregnant woman, there are medications we give to the newborn that cut this risk down by 80%. HIV targets CD4 T cells. Those are your helper T cells, and they're active against atypical bacteria, fungi, and parasites. So those are going to be some of the diseases that come up in patients who have low CD4 T cell counts. HIV is a retrovirus, so it's a viral genome that has RNA, but that RNA does not insert itself into the host RNA genome. It inserts itself into the host DNA genome, and the way it does this is by converting its RNA into DNA by reverse transcriptase. So normally you would go from DNA to RNA, but this reverse transcriptase allows the genome to be converted from RNA to DNA. So you're kind of going the reverse, and that's why it's called reverse transcriptase. This enzyme's native to HIV, and it's going to play a big role when we're talking about treatment for HIV, because this is the enzyme that's so specific to HIV that we can target this as an effective treatment. From onset to symptoms, the natural progression is about 7 to 10 years from the time you contract the HIV infection to when you start developing possible opportunistic infections. And the patient's proximate diagnosis is based on their CD4 count. That shows how likely it is that the patient is going to develop an opportunistic infection. And their viral load, that shows how infective the patient is. Okay, so who do we test for HIV? Well, really, we should test anybody who feels that they may have been exposed to HIV and relates a realistic possibility. But as the physician, as the provider, you should know what those realistic possibilities are. So, patients who have engaged in unprotected sex obviously should be tested for HIV. So that would include unprotected vaginal, anal, or oral sex, particularly patients that engage in male-male anal intercourse. Anal intercourse has a higher probability of transmitting HIV because the anal mucosa is a little bit less adept for dealing with that kind of trauma. Any patients who have used IV drugs or needles, any patients who have been recently diagnosed with another STD, chlamydia, gonorrhea, syphilis, pregnant women should be tested for HIV just because of the fact that they have obviously had sex, and because if they have HIV, we want to prevent vertical transmission to the baby. And then patients who have symptoms consistent with acute HIV syndrome. So the test is done as a blood test. There are newer tests which are done by swabbing the mouth. Those are newer. I believe the USMLE is going to want you to know about the blood test. So the initial test is, so you only draw blood once, and when it's sent off to the lab, the first test that's done is an enzyme-linked immunosorbent assay, ELISA. And this is a cheaper test, and it's a screening test. Now, it does have false positives. For instance, patients who have lupus can show up as a false positive on an ELISA. So it's not completely accurate, but patients who show up negative on an ELISA test are definitely negative. So it does give false positives, but if you show up negative on ELISA, you are definitely negative. All the patients' blood who show up positive on ELISA then go to a Western blot, which is a little bit more expensive, a little more time consuming, but it is the definitive test for HIV because you're actually looking for proteins that are from the HIV virus. So the Western blot is definitive. So you've got two tests that are done. You're only drawing blood once. ELISA is the screening test, and Western blot is definitive. So the natural progression of HIV from the point of infection, which would be here at 0 weeks, to death, which would be here at 10 to 11 years, and this is assuming that you're not taking any medications. This shows what happens to your CD4 count and what happens to your viral load. So what I want to point out is this notable period here about 3 to 9 weeks after primary infection, after the encounter took place where the infection was transmitted, about 3 to 9 weeks, where the viral load count jumps up so high, it's almost as high as it'll ever get in this patient. And the CD4 count has a precipitous drop. It drops down to 500. That's not significant enough to cause any diseases, but it's a significant drop because normally we hover above 800 up to 1200. So to have 500 is very unusual. And so the fact that this patient is going through this is because they have a wide dissemination of the virus. So basically, the HIV virus is establishing itself in the body. And so you get this massive response. And this is actually what causes the symptoms in acute HIV syndrome. So what is acute HIV syndrome? This is something that you might not ever come across, and even if you do see it, you might not recognize it. What it is it occurs soon after infection, and it corresponds with that rapid increase in viral load and mild drop in CD4 count. This can be asymptomatic. Patients might not even notice symptoms of it. It can be subclinical, or it may be symptomatic indeed, but gets misdiagnosed because acute HIV syndrome is not nearly as common as like flu. And really, that's how this looks. You get a fever, you get malaise, you get some swollen lymph nodes, maybe a rash. A lot of doctors confuse this with the flu, and it goes away. So you're not going to have the patient coming back saying 3, 4, 5 weeks later, I still have this going on. And a lot of patients will go on thinking, oh, okay, I just had the flu. But what you should know is that patients with these symptoms, it should be in their chart. Because if they come back later, down the road, then you could possibly pinpoint this as acute HIV syndrome. But I wouldn't say that having these symptoms alone, except for maybe the maculopapular rash, is an indication for HIV testing. Now, if the patient says that 4, 5, 6 weeks ago they had an encounter that was unprotected, then you're going to go ahead and get an HIV testing. But you're going to be doing that anyway. The diagnosis, the only way to diagnose that it is indeed acute HIV syndrome is HIV testing, which would be the Western blot and ELISA. And if they're HIV positive, you're going to treat them accordingly. So how do we treat the new patient with HIV? So all patients that have newly been diagnosed with HIV should be referred to a specialist. There's specialist physicians that deal primarily with HIV patients. But you should know as a general clinician what's going to be done. So first, they're going to be doing HIV viral genotyping. There's multiple different HIV virus genotypes. They're not all the same. There's different mutations. Some are more infectious than others. And so the viral genotyping is useful for the clinician to determine what the prognosis is possibly going to be. Of course, a CD4 count and a viral load, that's going to be repeated multiple times throughout the patient's life during the course of their HIV illness. And you want to test them for TB, because that can be an opportunistic infection if they already have TB. You want to test them for CMV. If they have CMV infection, if they have latent CMV infection, then you're going to want to go ahead and treat them for that. If they have any other STDs, so you're going to want to do a swab for gonorrhea, a swab for chlamydia, you're going to want to test them for syphilis with the VDRL laboratory, and then you're going to want to test for toxoplasma antibodies. You're basically testing for all the STDs plus TB and CMV. You're going to want to get a complete laboratory panel. You want to get your CBC, CMP, thyroid function tests. HIV can affect the thyroid, so you want to have all these baseline exams. But importantly, you want to have a liver function panel and a lipid panel. And the reason the lipid panel is important is that some of the medications that are given for HIV can disturb the lipid levels. And so again, you want to have a baseline level of what the patient's HDL, LDL, VLDL levels are before you start treating them, or before the point that you start treating them. You're also going to want to do an ophthalmologic exam. And you're primarily looking for any, you're primarily doing a baseline exam, so that if the patient comes back with visual changes, you can quickly note if it's CMV retinitis. And then these patients are going to want to be rechecked every 3 to 6 months. The therapy is going to be anti-retrovirals. However, when to treat them with anti-retrovirals is based on the CD4 count and their viral load. So we start therapy when the CD4 count drops below 350. Now notice that a patient with HIV might not reach a CD4 count of 350 for 4 or 5 years. So as soon as you diagnose somebody with HIV, it doesn't mean they have to go right on medication. They may, if their CD4 count is low right away, but in some patients, they might not have to go on medication for a few years. So it all varies. Also, if the viral load count exceeds 55,000, you're going to want to put them on anti-retrovirals. So 55,000 would be, whereabouts that? This is 10,000, so 55,000 would be about here. But again, you're gonna start them for that. So CD4 count less than 350 or viral load count greater than 55,000, you're going to start anti-retroviral therapy. So what is anti-retroviral therapy? It is the mainstay of therapy in HIV. It is the reason patients can live with HIV, and it's become so effective now that patients are living relatively normal lifespans with HIV. That's not to say that the therapy doesn't have its side effects, which can be a significant negative impact in the quality of life in some of these patients, but they are living longer, and living is better than dying, in my opinion at least. So before starting antiretroviral therapy, the clinician should get a viral sensitivity test to determine the most effective drug. So this is different from what we talked about here, which was the HIV viral genotyping. This is a viral sensitivity test, and what this is a lab test that takes the HIV virus that's in the patient's blood, and essentially you're testing its sensitivity to the different kinds of HIV drugs to determine what's the most effective drug for this patient, because all HIV viruses are not born the same. Different ones have different mutations. So you want to determine what the best drugs would be to give to this particular patient. And there's 3 classes of antiretrovirals that are currently used. We have our nucleoside reverse transcriptase inhibitors and our non-nucleoside reverse transcriptase inhibitors. Collectively, they're referred to as the reverse transcriptase inhibitors. The only difference is the nucleoside reverse transcriptase inhibitors are competitive inhibitors. The non-nucleoside reverse transcriptase inhibitors are non-competitive inhibitors. And then we have a class of drugs called protease inhibitors, which actually affect a different protein in the HIV virus. At least 3 drugs are always used, so you never have a patient on HIV on less than 3 antiretroviral drugs. Why? Because if you put them on one, the HIV virus is going to learn very quickly how to become resistant to it. So we always use at least 3 drugs. And the choices we have are 2 NRTIs, so 2 nucleoside reverse transcriptase inhibitors and a protease inhibitor, or 2 NRTIs and a non-nucleoside reverse transcriptase inhibitor. We could also use 4 drugs, where we would use 2 nucleoside reverse transcriptase inhibitors and 2 protease inhibitors, but that's less common. So just make sure you know that at least 3 drugs are used, and you always want to use 2 nucleoside reverse transcriptase inhibitors. So what are the nucleoside reverse transcriptase inhibitors? What these are they're just fake nucleotides, and they block the reverse transcriptase by competing for the nucleotide binding site. So if you want to look into the biochemistry of that, feel free, but all you're doing is you're competitively permanently blocking the reverse transcriptase, and that's going to inhibit the HIV virus from doing what it needs to do, which is creating a DNA genome to insert into the CD4 cell. So that's a good thing if you don't want HIV to reproduce, and I think we all would prefer HIV doesn't reproduce. So among the nucleoside reverse transcriptase inhibitors, the most commonly used is zidovudine, and the side effects from this are myelosuppression and GI upset. Now that sounds like 2 bad things, but compared to the other drugs, they're not. Those side effects aren't quite as bad. So zidovudine is the most commonly used. If you have to memorize one out of all of these, you should remember zidovudine. And sometimes it's referred to in the literature as AZT. Abacavir is a good one to remember. Even though it has a low side effect profile, it can cause a hypersensitivity reaction that can be quite dangerous, and that would manifest as a rash, shortness of breath, or myalgias. Of course, you should warn the patient before giving it to them. It doesn't happen in a lot of patients, but it should be monitored for, and if it happens, of course, you're going to stop therapy with that particular drug. Now, the rest of the NRTIs, besides zidovudine and abacavir, so didanosine, zalcitabine, and stavudine, can cause pancreatitis or peripheral neuropathy. Those are much more significant adverse effects, so we try to stay away from those if we can. 2 of the newer drugs, lamivudine and emtricitabine, are better because they have fewer adverse effects. So zidovudine is definitely the first one you're going to be giving the patient. Lamivudine and emtricitabine are other choices that are attractive. Abacavir, just make sure you warn the patient. Didanosine, zalcitabine, and stabudine are options, but they have significant adverse effects. So you're always going to want to have every HIV patient who's got a CD4 count less than 350 on 2 NRTIs, so 2 of these drugs. How about the non-nucleoside reverse transcriptase inhibitors? So in some therapies, we will have the patient on 1 of these in addition to 2 of the drugs we just talked about. Now these block reverse transcriptase by inactivating the enzyme itself. So you're not binding the active site, you're just blocking the enzyme. And there's 3 of these. Efavirenz is the most commonly used, and that's just simply because the most common side effects are fatigue and depression, and those are not, in the grand scheme of adverse effects, those are not that bad. We can't use efavirenz in pregnancy. So if a woman is pregnant, she has to stop efavirenz, and we would have to replace it with one of the other non-nucleoside reverse transcriptase inhibitors. And the other ones are nevirapine and delvaridine. And the side effects for the NNRTIs are rash and hepatotoxicity. But you should remember that efavirenz, most commonly used, but also contraindicated in pregnancy. Most patients will be on 1 of these, but you don't have to use 1 of these necessarily in therapy. The other class of HIV drugs are the protease inhibitors, and what these do is they block an enzyme responsible for manufacturing a mature HIV virion. So the other 2 drugs were responsible for sort of the insertion of the genome into the host cell. Protease is actually responsible for sort of making the final trimmings on this new HIV virus, and it prevents it from going into maturity. So in general, there's a lot of protease inhibitors, but in general, the adverse effects are all the same. They're liporedistribution, so you're not necessarily gaining weight, but your fat is moving to different spots in your body. Lipid disturbances, so remember why you want to have that lipid profile, and then GI upset. So what's important here is liporedistribution, because you'll see this a lot, and lipid disturbances because it's something you're going to want to monitor. If you have a 70-year-old HIV patient, then lipid disturbances can be significant because they're already at risk just by their age of coronary disease. This is a patient who has lipodystrophy due to his anti-retroviral therapy. You can see doesn't appear to be an overweight patient from the shoulders up, but his fat collection has developed on the abdominal area, but above the chest he appears quite slender. So this is lipodystrophy. Lipo meaning fat, dystrophy meaning bad form. So the regimen is going to be always 3 or 4 meds. So we're just reviewing here, and it should always include 2 nucleotide reverse transcriptase inhibitors, and the third can be either a protease inhibitor or an NNRTI. Efavirenz is preferred in non-pregnant women. In pregnant women, we're either going to use one of the other 2 protease inhibitors or a non-nucleotide reverse transcriptase inhibitor. We can also use a 4-medication regimen, and in that case we would use 2 non-reverse 2 NRTIs and 2 protease inhibitors. Now, what we call this therapy when we're using multiple drugs to treat HIV, this is known as highly active anti-retroviral therapy, or HAART. And you may have seen in some of my lectures me referring to HAART. Now you know what it is. So highly active anti-retroviral therapy. That's the regimen, a good regimen for treating HIV. The goal, and this is very important because this is going to tell you if what you're doing is effective. The patient should be rechecked within 1 month, and the viral load should be cut in half of what it initially was when the patient started therapy. So if they started out with a viral load of 75,000, they should be below 37,500 after 1 month, after 30 days. Ideally, though, it should at some point drop to undetectable levels. And at the same time, the CD4 count will also rise. And you can see how these 2 things play right into one another, because what happens when the viruses reproduce and they go out into the blood is they destroy a CD4 cell. So if you're slowing down the production of the HIV virus, you're going to increase your CD4 count just because fewer CD4 cells are being destroyed. So the goal, cut the viral load in half in the first month. And then, of course, you're going to monitor the patient for HIV metabolic syndrome, which is that disturbance in lipid panels that I mentioned with any patient that's on a protease inhibitor. And that's just going to be done with serial lipid panels. Now, what happens if the patient has HIV and they're pregnant? Regardless of whether the woman is regardless of what her CD4 count is, she's always going to be recommended zidovudine at least during her pregnancy. So during the first 14 weeks, she's taking zidovudine, and then after 14 weeks of gestation, then you're going to give her an additional 2 drugs. So you're going to treat her like you would treat any other HIV/AIDS patient. The difference is she starts out with zidovudine for the first 14 weeks of her pregnancy. First 14 weeks, until the baby is 14 weeks of gestation, we'll say it that way. And then once the baby is past 14 weeks of gestation, then we're going to add an additional 2 drugs. And again, those can be 2 nucleoside reverse transcriptase inhibitors. It could be, it could be 1 non-nucleoside and 1 nucleoside reverse transcriptase inhibitor, or it can be 1 nucleoside reverse transcriptase inhibitor and 1 protease inhibitor. Basically, 14 weeks of zidovudine at the very beginning until 14 weeks of gestation, and then after that, you're putting her on just regular old heart therapy that you would put any HIV patient on. The only drug that's contraindicated, as mentioned, is efavirenz. Now, during delivery, if her viral load is less than 1,000, which it should be if she's on effective therapy, then it's perfectly safe, and it's even recommended that she have a vaginal delivery because the complications from having a C-section actually outweigh the complications from having a vaginal delivery. And this, of course, is provided that there are no OBGYN contraindications for vaginal delivery. So if she's had 2 C-sections in the past, of course you're going to give her a C-section regardless. But provided she has no contraindications for vaginal delivery, if her viral load count is less than 1,000, she can go ahead and have a vaginal delivery. Otherwise, she's going to get a C-section. Now, when the baby is delivered, the baby should be on zidovudine. You can stop the zidovudine in the mother soon after delivery, but the baby should be on zidovudine from birth for at least 6 weeks, and the baby should be monitored until 18 months. When the baby is checked at 18 months and gets a regular HIV test like anyone else, and then comes back negative, then you have a definitively negative HIV baby. As long as you follow this regimen, the odds of vertical transmission from mother to baby is very, 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 very low now. And then also important to tell your pregnant HIV patient no breastfeeding at all. Never, 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 never. Okay, how about post-exposure prophylaxis? So this comes up in multiple different ways. You could have a patient come in and say, I had unprotected sex with somebody that has been diagnosed with HIV. What should I do? Well, you can get, depending on how long ago it was, you can get an HIV test, but what you should do is you should start them on a post-exposure prophylaxis. Why do you want to start them on a post-exposure prophylaxis? Because you do actually, depending on how far out you are, obviously if they said it was 2 years ago, it's one thing, but if it was 2 weeks ago or even a month ago, you can reduce their risk of converting to HIV positive. So you should start them on a heart therapy for 4 weeks, and it should include zidovudine. So basically, you're going to put them on 3 medications, just like any other HIV/AIDS patient, but always it should include zidovudine. And then any heart therapy would work though for 4 weeks. After those 4 weeks, you should test them for HIV like you would anybody, and if it comes back negative, the patient is indeed HIV negative. Zidovudine itself reduces the risk by 80%. So that's pretty exciting that we can just give the patient one pill, and if they take it for 4 weeks, they've reduced their risk of actually becoming HIV positive by 80%. All right, and that's all I've got for you on HIV.